hello again and welcome to another episode of RTMatters, where candid conversations take place about what matters most to respiratory therapists. I'm Patrick Dunne, your host, and I'm delighted to welcome you to this episode of RTMatters. Just a quick reminder, all episodes of RTMatters are available through your podcast app of choice. No access, no charge, no subscription fee, no membership. All right, now let's move on to episode 14, the impact of staffing issues on RT and patient health and well-being. As many of you know all too well, practicing in a hospital over the past few years has brought a whole new set of challenges. The working environment has shifted drastically. And while COVID-19 brought the role of the respiratory therapist into the spotlight, we're now dealing with a new and growing silent crisis, one of adequate staffing. Respiratory therapists, the frontline experts in cardiopulmonary assessment, ventilator management, aerosol drug delivery, airway clearance, chronic disease management, are leaving the profession in alarming numbers, creating one of the major staffing issues. But as we'll see, there are also other considerations as well. And today we're talking about why this is happening, what it means for respiratory therapists, and equally important, perhaps more important, our patients, and how we should go about addressing the problem. It's a tough conversation, but one we need to have. And I am delighted to introduce to you our invited guest today, who really does have an awful lot of expertise in this area. Garry Kauffman. He's the managing owner of Kauffman Consulting, located in Walnut Grove, North Carolina. Garry is a registered respiratory therapist. He's a fellow of the American Association for Respiratory Care. He's also a fellow of the American College of Healthcare Executives, and he informed me he was just notified that he now has life tenure as a fellow in the American College of Healthcare Healthcare Executives. And that's really important because that means he's donated a lot of his time and effort to that organization. Throughout his distinguished 40-plus year career, he has had various positions in respiratory care. He was a clinical respiratory care coordinator, director of clinical education, and administrative director of respiratory care departments. But he also segued into management positions in healthcare systems. He was a former director of operations for the York Healthcare System. He was a chief executive officer of Select Specialty Hospital, which is an LTAC located in Pennsylvania. And he was also the chief executive officer of an orthopedic surgeons group. So he's had great experience, not just as a respiratory therapy director, but also as a director in operations and organization. Throughout his career, he has had professional associations with the Pennsylvania Society for Respiratory Care, as well as the North Carolina Society for Respiratory Care. He's also been very active involved in the AARC. In fact, we shared many of our common endeavors together, working on committees and lectures and promotions like that. He's a former president of the AARC, so he serves on the President's Council to this day. He also has served on numerous committees, as I mentioned, and way back when the Uniform Reporting Manual was still operative, and we'll talk more about that in a moment. And more recently, the Self and Effective Staffing Guide that was replacing the Uniform Reporting Manual in 2021. He's also the Charter Affiliates Consultant for the AARC. He is also involved with activities with the American College of Health Executives that I mentioned, and also an Association of Healthcare Value Analysis Professionals. So he certainly has a broad range of experience in terms of some of the issues we're going to be talking about during this podcast. He's widely recognized as a national presenter, and he has delivered more than 300 respiratory care programs, many of them for continuing respiratory care education credit. Garry, I'm delighted to have you join us today, and welcome to RTMatters.
Thank you, Patrick. And so our attendees know Patrick has been not only a mentor, but a good friend. And when I need an answer to a question, I say, hey, Patrick, and he provides it.
Well, we all try and help out another, and that's the whole idea of what we're going to be talking about today. Now, one of the things we do at RTMatters, Garry, as I mentioned to you, is we always like to have our listeners hear about how our invited guest actually got into the profession, because we are all recognizing we took a different pathway. And as I pointed out, before your RT training, you actually graduated with a baccalaureate degree in pre-healing arts way back in the mid-1970s. That was a pre-med. Was that a pre-med program that you were involved in?
Yes, it was.
And well, how did you wind up as an RT?
Well, I'll give you a quick story. It all started when I was 6. On my 6th birthday, I got a horse. And I knew I wanted to be a physician, hence leading my entry into Franklin Marshall program. And my goal was to be a country doc that would ride my horse to do home visits.
Marcus Welby on four legs.
It was a horrible, horrible business plan. But when I think back on it, I had some ideas about efficiency and safety and efficacy. Well, the long story was I had A's in high school, but by my junior year at Franklin and Marshall, I had a solid B average. And honestly, Patrick, there was no medical school in the United States that wanted me with a B because they had plenty of A students. I did get accepted to programs outside the country, but I don't know. Stubborn Dutchman, I guess I didn't pursue those.
Well, when did you first know about a respiratory therapist?
Well, in my junior year, when I got kicked away from medical school, my mom said, call your godfather. So I called my godfather, who was an RN of critical care services, we call today, and also transport. And what he said is that back in the paper days, he took a piece of paper and he had a Monday through Friday schedule for watching different folks in different departments. And Monday went by and I went through imaging. Tuesday went by. I went to a laboratory. It just didn't click. But Wednesday, the skies opened up and I found not RT, IT. So here was what I saw.
Back in the day, it was inhalation therapy.
Yep. Apparently, we did not have that exhalation phase in our scope of practice, but we got that later. The director of clinical education, the program that I eventually went to, took me out first rounds, and he assessed a patient by giving a breathing treatment, yes, with an IPPB machine. And what I noted was that he just didn't move the knobs. He talked to the patient, explained to the nurse who came in what he was doing. He recorded in the paper chart his assessment and recommendation for change of care, the respiratory care plan. And then we went and did a blood gas. And
where did you actually have your entry into practice? At the same facility that you did the shadow?
Well, yeah, that was actually, as students, we were allowed to work part-time, basically as OJTs. Once we got cleared during the day shift, we could work evenings and nights, and that was a lot of it. But Patrick, I've never looked back. That IPB treatment, that blood gas, that ventilated patient assessment, I'll underline patient ventilator assessment. Mm-hmm. I knew RT was for me, and I never looked back.
That's good. Well, you vanished your training program, and then you obtained your registry. You became a registered respiratory therapist, and you worked several years in various positions around Pennsylvania, where you're from. But you decided to continue your education, and you went back to Penn State and got your master's degree in the 1980s. What prompted you to continue your education, especially a master's degree in public health?
Well, two things. One, I looked around at colleges, and we're married and had young kids, and certainly I had to do it evening school, and I just I'd say Google today. I called it back in the day, and I found Penn State had a program, Masters of Public Administration, with a health track. I thought, this is good. I went up and interviewed. But what really caused me to do that were two factors. One, and this is back in 81, the healthcare system, which I heard you talk about in a former podcast, was a fee-based system. The more you did, the more charges you dropped, and the more the hospital made. Life was simple. Maybe it wasn't good, but it was simple. And what we learned that the federal government was saying, nope, we're not going to do this anymore. Mm-hmm.
That was a change from fee-for-service to the DRG reimbursement rate, which is a fixed amount, capitated amount based upon the patient's diagnosis.
And that was a total transformation, unlike anything the healthcare system has seen at that time or since, in my opinion. Mm-hmm. And I thought, I know how to do accounting. My dad's an accountant. I grew up and working part-time in his business. It wasn't the spreadsheets. It was that this is the first time where we had to fundamentally look in that mirror and say, what are we doing? Why are we doing it? What are the alternatives? And what is the science?
Yes, back in the day, I remember very distinctly, there was a lot of fear and uncertainty. Is respiratory therapy going to survive? Because we were known a revenue generator department. And now all of a sudden, fixed amount, we became a cost center. And that was a tremendous challenge, and we survived.
Yep. And I think back, and I mentioned it later, my master's project was actually looking at, and this would have been 85, 86, I guess, was looking at burnout in Pennsylvania RNs and RTs. And I say this because, Patrick, you and I talk about social media, and there's more negativity out there than positively, certainly. But the sky is not falling. It's cloudy. But I go back to my study. The burnout in RNs and RTs was over 80%. And that was because of DRGs, short staffing, growth in need for all clinicians, including respiratory therapy. So as much as people say, why did I get into this? The sky is falling. I have to tell you, we've been there before. This may be a tougher patch. In fact, I think it is.
Yeah. Well, what are the words of wisdom you would share with RTs now, especially new graduates who are just entering the profession, about obtaining an advanced degree and to do so sooner rather than later?
Yeah, sooner. Sooner is better. Absolutely. And I'll give the example, Mike, going back to my boss who encouraged me to go to graduate school. And that was, if you don't have the degree, you may not be invited to the meeting. And I go back to the statement I heard Sam Giordano say many years ago: if you're not at the table, you're on the menu.
That's right. Well, I also like to quote misappropriated to Benjamin Franklin, but it's wasted time is one of the only things in life we never get back. So what you're basically saying is prepare yourself now academically for future opportunities that'll come down the road if you want to be at the table. And I think that's a very important admission.
Absolutely, Patrick.
All right. Let's get to the topic for this episode now: impact of the staffing issues on respiratory therapists and patient health and well-being. Let's begin our discussion briefly listing the major staffing issues. And there are three, as we discussed: staffing shortages, threats of staffing cuts, and unexpected staff resignation for a variety of reasons. First of all, what do you say is driving the staffing shortage?
Patrick, I think there's several issues, and I'll use the analogy of a bucket and a faucet. So back in the day, that faucet was turned on and it was delivering respiratory therapists to meet actually an increasing need, patient demand. Life was good. In fact, that bucket was always full. What we've seen in the last 3-5 years or so is that the faucet is opened even more. So the aging population, particularly those that are living longer, both healthier and with chronic diseases, that faucet is turned higher and higher and higher.
Right. The demand is going up, and we also have a problem with the age of our existing workforce, don't we? Right now.
Our patients are getting older, and guess what? We're aging with them. In fact, a statistic I looked up just last night to get the most current number, the Bureau of Labor Statistics, the federal government, says that the need for more therapists is somewhere in the range over the past year of 11 to 14%. So now we've got that faucet even opened even more. And here's the third issue. The bucket has a hole in it, unlike ever before. We're losing significant numbers, in fact, tens of thousands of RTs. Patrick, you and I are in that age cohort.
That's right.
Let's just say it's 40 to 50, but it's not. It's over 55.
What about the next group coming in, the replacements from the entry-level programs around the country?
Well, and that's the two issues. One is the largest cohort of our workforce is the one that you and I are in. 40% of licensed therapists will not be here within the next decade or so. And here's the third leg of that stool. Our schools are somewhere in the 50 to 60% full. It's just, you got a big faucet, a bucket with a hole in, and this is really where I think we've talked about. This is the rough patch. It's going to take some time. Now, I'm going to quickly say that the one way to manage that faucet, that demand, is to use protocols and evidence-based medicine, which is in the Safe and Effective Staffing Guide.
Right. And we'll talk about that in a moment, because we want to get on to one of the solutions that are out there. Right. And also, the enrollments are down about 27%. I'd just like to point out to our listeners that morerts.com is a collaboration between the American Association for Respiratory Care, the National Board for Respiratory Care, and the Commission on Accreditation for Respiratory Care. It's a collaboration to try and get more people to be aware of the profession. At the same time, there's also the Future Health Professionals, which is an organization to go into high schools and tell students about health occupations. And the AARC has collaborated with those groups on a state-by-state basis to go in and collaborate and go to some of these presentations in high schools to encourage the opportunity about respiratory care. So there are efforts underway to try and address the decrease in enrollments. Now, let's get on to the characteristics that we see with staffing shortages. And as I mentioned, there are several different issues we'll talk about. What are the characteristics of a chronic staffing shortage in your mind?
I think the first is losing their autonomy as assessor therapist. And where we see this is in those departments that don't utilize patient-focused, RT-managed or RT-driven protocols. Now, as what managers will say, and you see this on Leadership and Management Connect AARC, is they're using more overtime, so there's wear and tear in your current staff, and more agency therapists. Now, these are all good people. Don't get me wrong. This is not a knock against agency, but they're paying upwards of $150 to $200 an hour to the agency, not the therapist, by the way, but to the agency.
Right.
And I talked to some HR professionals right before the holidays. I said, how are you measuring all this? And here's 3 of their key metrics. And I think our listeners should be thinking about this. The first is turnover. Now, turnovers, we need to understand the reason for it. If I'm burned out and I leave the profession, that's the worst. If I don't like how my department is run because we don't use protocols, that's on the manager and the medical director. We'll talk about that later. So they look at turnover, both absolute and transitional. They look at employee satisfaction, which is actually an antiquated word we should be using, engagement. The third thing they look at, and this is where we can quantify as leaders, whether we're staff therapist or manager, is days to hire. Back in the day, I remember very well, we would post a position and we would have applicants that day, posting in the paper, by the way, not on the internet. The days to fill have gone from days to weeks to 4 to 6 months. This is what the HR professionals tell me. Right. So when you get a vacancy, you're short, and now you're waiting 4 to 6 months, not counting orientation.
To underline your observations, Andrew Miller and colleagues put an article in Respiratory Care in May 2023, a survey they did. And they said workplace-related stress and burnout is associated with ineffective leadership, inadequate staffing, and high workload. So, I mean, you're actually re-emphasizing what they found out when they did that survey of a selected group of respiratory therapists. Yes. Now, what about this excessively high patient-to-therapist ratios? How does that affect the morale of a respiratory therapist wanting to do what you suggested we should do, but yet because they're so overwhelmed and they can't I point out, in a mistreatment situation, that's a medication error, and that's a patient safety issue. So you just don't stop giving treatments. You have to have a process in terms of determining who needs the treatment, when they need it, and why they need it.
All the more reason we need evidence-based practice to be our foundation. Well, yeah, and you're right. Delays are missed. In Pennsylvania, it's the only state that has a patient safety authority where you must report delayed or missed treatments. Now, one of the ways that you reduce that is to eliminate those that don't need to be ordered in the first place.
Yeah, we call that low value respiratory care, which is expensive. It's ordered, but there's no significant improvement in the patient's condition, and it's more tradition than the actual patient need. But because it was written by a physician, it will be delivered.
Right. And you can't go against the physician, as you and I well know.
Yeah.
We see more error rates. And what's interesting, if a hospital, I was just talking to someone last week, if a hospital doesn't have enough nurses, what they can do is shut down the unit. We don't get that luxury. Right. And I think that's something that drives respiratory therapists. Patient satisfaction and family satisfaction. And the final point, Patrick, and this may be the most critical for us to land on, is executives are looking at continued vacancy rates and saying, what's plan B? And I'll talk about that a little later when we talk about the challenges for maybe losing the ability to deliver our care to other caregivers.
Right. We did an episode on that with talking about some therapists, including the state of California's licensing boards, are authorizing hospitals. You can actually transfer, quote, non-routine procedures to non-respiratory therapists. And of course, that just is not something we want to do. We want a respiratory therapist who understands the technology and has the ability to patient educate to the point that they can take care of themselves once they leave the hospital. But boy, I'll tell you, this idea of using substitutes, whether it's an LVN, a medical assistant, or an EMT, it's a short-term solution to a bigger problem.
Right. I think something, Patrick, you told me about some years ago is we need to move away from using the term giving a treatment to make that a therapy session.
Yes.
And that denotes that there's assessment in there. And LPNs, good for what they are, by the way, they are not licensed to assess and change a care plan. Only RTs and certainly RNs and APPs and docs are.
Yeah, there's no question that's another alternative. And one last issue here is that let's say we have a hypothetical department, and we had this discussion online a couple of weeks ago. They have a pretty good staff. They're pretty much on where they want to be. They have a good, engaged, informative medical director. The administrative director has done all the right things. But then all of a sudden, because of the pressures of the budgetary system in each hospital, they're all suffering because of uncertainty in reimbursement, Medicaid disenrollment. And the consultants come in and they say, 60% or more of your budget is personnel. Let's take a look at that as respiratory therapy department. And then all of a sudden there's a rumor we're going to have staff cutbacks. What does that do to the morale of the department?
Well, it's easy to say. It's that administration sees this as ancillary staff, a phrase I hate, rather than a clinical service. And it just runs through from the manager. I don't even say the medical director, because we're put as a second-class citizen based upon getting the treatments done and getting them done on time rather than assessors.
Yeah. The therapy session is really what I copied from my colleagues in physical therapy. The physician writes a PT consult for the knee replacement or the hip replacement. Physical therapist does an assessment, comes up with a plan, and implements it. And I think that's the way we need to get away from what which I borrowed from you quite a few years ago. Q4 albuterol till out the door. It's ordered, and the patient is not in exacerbation, so they don't need short-acting beta agonists, but yet because it was ordered, you have to give those treatments. So the assess and evaluate protocol is a much better way to go. What about this threat of cutbacks, unexpected resignations? How is that different when people say, I've had enough, I've worked 10, 12-hour shifts, I can't get any rest? What does that mean?
Well, if you think back in the day, most departments work 8-hour shifts. So if a night shift person called in sick, you'd say the evening shift, somebody stay half, days come in half. With most all departments working 12, that really stresses out, because you can't say, hey, you work 12, can you do another? So I think that's one thing. The other thing is I've never seen this magnitude of vacancies. And it's not that my observation, it's what is reported. The serious concern that I have is that month after month, year after year, others looking at that and saying, well, it's not you. You've got great therapists. We love them. There just ain't enough of them.
Right. Now, how does this continual non-resolved workplace stress that you mentioned, how does that affect RTs, the individual professional? How are they affected by this continual non-resolved stress? High workload, high patient ratios, a lot of unscheduled or scheduled overtime, unexpected overtime. How is that affecting the RT physically and emotionally?
Call outs. I hear managers saying all the time, I have more call outs than I ever had. I need a mental health day. We've heard that term. It's used more frequently. The other one that I've seen, and I have two good friends that let me throw on scrubs a couple times a year so I can get back in the trenches and remember what I did at one time. And I went on rounds and went to the break room after this med-surg rounds, went to the break room. I looked in the face of 3 people. I saw resignation, dread, just dispirited. And by the way, those 3 people were not respiratory therapists. It was a fellow, an attending, and a nurse. So I think the point needs to be made. It's just not us.
That's right.
We're RTs and we feel it. It's been bad. It's just not us. When you look at the statistics for nursing, it's a horror show.
Oh, yes, very much so.
Show.
And then, of course, the consultants that we'll get to later say, well, the nursing division can take over those respiratory treatments, and they already have an overflowing plate because of the same issues. What about the physical effects on the RT that we need to really address? Because, suck it up, you hear that, just don't whine, just big boys don't cry, go in there and do it. What are some of the actual physical effects of this unrelenting stress?
Sick time, inter-team disagreements, intra-team disagreements, decreased job or engagement satisfaction as measured, and psychologically, I'm not a psychologist, certainly, but irritability, apathy, you just see it, and it's growing and growing and growing. Now, I know we're talking negative stuff here, Patrick, but I don't think we want our attendees or our listeners to think the sky is falling. It's gray. There's no doubt about the sky is gray, but as we own our profession and own the science of delivering, those are the tools in the toolbox to help some of this be ameliorated.
Well, let's move on to that. It's a nice introduction to what we really want to talk about, which is how to determine and justify optimum staffing patterns. And we continually hear of the importance of correctly and accurately measuring a respiratory therapist's clinical productivity. External consultants come in and start getting the ear of the hospital executives, and all of a sudden they make recommendations. What are they basing their decisions on to the CEO in terms of staff cutbacks?
Most hospitals, the majority of hospitals, are in the red on patient care services. And that's why the consultants are brought in. The formula, the contract with the consultants is typically they always get an upfront amount, and then they share in the reductions. And we should never, ever forget that's the formula. If a consultant comes in and uses their productivity metric and it shows that respiratory therapy department needs more staff, you're never going to hear it. You're just absolutely never going to hear that as a recommendation. That gets slid off the report. I'm not blaming consultants. They're doing what they're asked to do. But I will say, going back to the vacancies, the consultants see those vacancies and say, look, you can't fix it. It's not your problem. I mean, it's not your fault. We'll find another care delivery model, team nursing, by the way, that can get those done. I think the issue for us, Patrick, is that we need to understand, particularly as department heads, what is the only validated system to accurately determine clinical FTEs.
Okay. Well, what do the consultants typically focus on when they try to, quote, measure clinical productivity?
They have 8 or 9 metrics that they look at. And you and I, Patrick, we would look at those. We'd run the numbers and see which one we like best, which one has the greatest cut. Again, not bad people. The 3 that are top, that are most used, are CPT coded procedure count, APCs, ambulatory payment classifications. By the way, that's the outpatient DRG system, in case you want to smile and laugh at that one. And the third is inpatient census. None of them for respiratory therapy have been validated, and they cannot accurately predict our clinical FTEs.
Okay. And at the same time, our productivity. Why, therefore, is it vital? And I think I already know the answer to this. Why is it so important for our profession to accurately and continually measure, monitor, and report clinical productivity? And we'll talk more about how we can do that in a moment. But why is that such an important point right now?
I started with this. I'll end with this. I'll say it right now in the middle, because patient matters. Our patients matter. Nothing else is more important than delivering safe, evidence-based, effective, and I might add, cost-efficient care, because patients matter.
Mm-hmm. Under protocol-directed care, actually.
Evidence-based.
Evidence-based. And when we start capturing this information in terms of clinical productivity, which we'll talk about our metrics in a moment, who does the information get shared with for the greatest bang for the buck, so to speak?
First of all, our team medical director must be educated and engaged. If not, that usually is a non-starter. I can't go to administration, finance, IT, COO, and make a case on the quality of care that we wouldn't have like a physician can. So the first is we got to get our docs on board. And Patrick, you and I were talking about this over actually the last few years, more than a few years. Where are we? Are we arm in arm with our medical directors? If not, step one. Step two, your administrator, that could be a doc, a nurse, a COO, whomever, needs to understand the math. We need to show them the math that's been in place since 1980 that is validated. And thirdly, we need to do the A/B comparison. Here's the math from the validated system. Here's the math from the unvalidated system. It could be we have too many staff. It could be we don't have enough. It could be we have the right amount. But you need to do that A/B comparison with physician, executives, finance, and I might add, which no one thinks about, chief compliance officer. Why would the chief compliance officer want to be involved? Or why would we want them to be involved? Like you said, Patrick, we have to report missed therapies.
Right. Now, another point that I wanted to bring up about the medical director, I think we have to recognize, and we've talked about this previously, they're also the advocate to the medical staff. And when you get the medical staff behind you in terms of what they want for their patients, it's a whole new area of camaraderie that we have. So the medical director, not just the administration, but also is the liaison to the medical staff. And hopefully we'll be able to help some type of process to help potential medical directors get a better handle on what it is that their responsibilities will be.
Yep,
Now, let's talk about this great resource that we briefly mentioned, the AARC Safe and Effective Staffing Guideline. That actually replaced the Uniform Reporting Manual, which for 30 years was around. And in 2021, it was rebranded and reworked to become the Safe and Effective Staffing Guideline. As I mentioned, you were a big part of that transition. What is the key value of what we call now the SESG, Safe and Effective Staffing Guide? What is the key value of that particular document?
Well, Patrick, most people, myself included, when we would get the URM in the mail in a 3-ring binder, it had 5 or 6 chapters, but you'd turn to the one on the numbers on productivity. That's still the case because if we don't have the right number of therapists to deliver care, the rest of that resource doesn't matter. So the primary focus is documenting, accurately calculating the clinical FTEs that are needed for your particular department.
And that's based upon the patient need and the procedures that are provided for in that particular department. So it can be tailored to whatever hospital's scope of practice happens to be in the respiratory care department.
Yeah, good point, Patrick, because the list of procedures in, I'll just call it the guide, easier to say, the list of the procedures, it may be 75, 80% of what a department does. But if they do additional, and everybody does, procedures, then within the guide is a whole chapter on how to create your internally validated procedures.
And the thing that's nice is that our scope of practice is continually expanding. And so new technology comes out, and now all of a sudden we have a mechanism to accurately capture how that's going to be delivered to the patients in our hospital.
Yep, the methodology can be used. In fact, Rick Ford, who I call the godfather of the URM,
yeah, Rick Ford is the retired administrative director of the Respiratory Care Department at UC San Diego,
yes,
and was a key person involved way back when the Uniform Reporting Manual was first being developed.
He was the guy. I served on the first edition, and Rick did 2 through 4, and then he and I worked together on 5 and 6, along with our team, by the way. And I mean, Rick and I chuckled for decades when we looked at these unvalidated productivity metrics and what the staffing would be. Those directors that could show that A/B comparison kept their staff. Others lost staff and none gained.
Yeah. Why are validated time standards? And we want to come back and nail that. A validated time standard means that there's evidence to back it up. It's not just something you pull out of the sky. And why is that so important for our profession right now?
Well, I'll give you an example, Patrick. If we use CPT-coded procedures, and you and I get our workload, as we call it, at the start of a shift, you get 20 units and I get 20 units. You get 20 nebulizers, I get 20 ventilated patients. Obviously, I'm not being facetious. I'm being facetious with that. Moving from counting everything as a 1, which is what the other systems do, to a system that understands the time value of a procedure. And the other comment I would like to make is that we don't do this. We don't sit in a room and make these numbers up. This is a national survey. It's been done that way through all 6 editions. And then a third party, not the AARC, not our group, or now a committee. We don't touch the numbers. A third party, the NBRC, I might add, and thank them once again, Lori and her team, does all the statistical analysis. When they send it back to us, we know and users know that we've not fluffed the numbers. So when it says a nebulizer treatment takes 15 minutes, it takes 15 minutes as the median. A ventilated patient day, 156 minutes. That's the truth, because the people on the front line say, this is how long it takes.
That statistically validation is very important, because now all of a sudden, and especially having a third party who has expertise in statistical analysis because of their exam building process, is very important. One of the common pushbacks we hear, and Arthur Miller also wrote an article about the low pickup of the guide. One of the common pushbacks we hear is, sounds good, but it just won't happen here. How do you overcome such pessimistic view?
It's interesting, Patrick, because we've surveyed in my time 3 surveys, and we asked, do you use it? And over 80% said yes. But you look at the number of units sold, it doesn't equal. So what folks are doing, they're using it in the background. And I did this too. And one year I didn't have any budget, so I bought it myself, so I could show my boss, here's how many we need, and here's how many this other metric says. So the use of standardized procedure times is the majority. Some of those are homegrown, and actually that's okay if you do it right. But in terms of those that say they're allowed to use it and it's used to determine staffing, it's a minority. And that's unfortunate. An example I use is, how many RNs do you need in a 10-bed unit? Each bed is filled with a patient that opens heart surgery. Answer, 10. When you go down the hallway, that med-surg unit, 10 beds, how many RNs do you have? 2, maybe 3. Why is that? When they answer it's based upon the patient need and acuity, I say, we got them. Because that's this system, which predates, is older than any other productivity system in the U.S.
Now, another refrain we hear, and we're seeing counters to this, and I'm sure you can help us illustrate this, that the guide just can't be integrated with our electronic medical record system. Is that the case?
No, it ain't easy. Put it this way. But here's how it does, and this is probably enough content for another podcast if you'd like to have me back, because this is critical. The vast majority of folks that say, I like to use it, but I can't, 2 barriers. Administration already has a number that they like. We talked about that. And secondly, it doesn't fit in my EMR. Well, here's the short answer. It does. Many departments have integrated. Within every EMR is a charge master, or procedure master, I should call it, and has a list of procedures and what you charge. All that needs to be done, not this easy, is to add the additional procedures in rows, add a column that has time. So today, and I'll make up some numbers for our discussion, you do a nebulizer treatment, you click an Epic, Cerner, Meditech, whatever your EMR, they're all the same in terms of capturing clinical interventions.
I should point out that the first episode of Epic, developed by a nurse, was basically for charge capture. That was way back before DRGs. It was to capture every item that was dispensed. And that's why that is such important. And that charge is nothing more than just what the hospital allocates for the cost of that particular procedure. That's not linked at all to reimbursement.
Right. I mean, there are some exceptions where charge-based or cost-plus models. But when that nurse clicks on that, or that therapist clicks on a neb, what that generates is a charge. We call it dropping the charge. And by the way, some hospitals use charges to determine staffing. So all that needs to be done, another hour conversation, is to add the rows for the procedures not captured, a column for procedure time. And if IT or finance or whomever doesn't want a dollar charge associated with that, maybe a patient mobility session, you put a 0 in.
Now, we tend to focus this discussion on clinical productivity and the equation to staffing, and that's important for patient care. But the guide also includes other important tools that you alluded to, which is value efficiency. What else does that do, and how does that help our cause?
Well, and let me just say quickly, there's an annotated bibliography that is best I've ever seen. And if someone needs to know, how is there a protocol for this, you go in and search it and you get it. So the annotated bibliography, the case studies and value and CPGs and value efficiency.
CPGs, clinical practice guidelines. Right?
Yes, that's a new chapter that Linda Goodfellow wrote and has all the links to the AARC.
And Linda is the AARC's go-to person for converting the clinical practice guidelines from expert panel to evidence-based documents.
Yep. And what we added in the current edition was that to make it one-stop shopping, a click and you go right to it. I'll get to value efficiency in a second. The other chapter that really is important, it's called case studies. And there are 3 of them. How to integrate your system within your informatics. And we've got a number of departments. They show you how to do it. Just follow it. The second case study is how to make the case, how to educate and engage your key stakeholders to adopt it. And the third one is how do you utilize this to match patient demand to your staffing? And within the guide are downloadable staffing templates that we've had in the last several editions. It's plug and play. Now, value efficiency is the newest. I heard Rob Chatburn talk a decade ago about this, and I talked with him, and quite honestly, it just kind of didn't make the front burner. And as Rick and I were putting together the first edition of the SASG, we called Rob and said, this is a thing. We need to bring this back. So Rob and Rick and I put together a paper published in Respiratory Care on value efficiency, to which Dean Hess wrote an op-ed to it. And it's a concept that, quite honestly, Patrick, you and I learned decades ago, but many of us are not practicing. And there's 2 components. How long does it take? That's the efficiency part. That's important. But the other part is, what is the clinical evidence that supports it? And that rubric, in fact, we're working on the second study now. Hopefully we'll submit for publication later this year. But that rubric is complex. But basically, I say value efficiency is delivering evidence-based respiratory care in an efficient manner.
There's no question about it. And that's why we have to be so important in terms of addressing this. I decide value, and I think a lot of the early proponents of value-based healthcare is that the patient conditions improves as a direct result of getting what you just said, effective and evidence-based care. And if we're giving care and there's no marginal impact on the patient status, albuterol, after we've already addressed the exacerbation, we're wasting resources. And at the same time, not giving that does not adversely impact the patient's health. See, so it's really kind of a whole big concept that's much different than what we started way back prior to the DRGs. All right, now let's summarize up here and talk a little bit more about what our listeners can do. This is a very provocative question. How can and should bedside therapists, staff, clinical practitioners advocate for the adoption of the guide in their respective institutions? We always hear, well, that's not my job. That's the administrator's job. That's the director's job. But yet you and I are talking about the fact that the people who are at the bedside really have a responsibility, not to their patients also, but to themselves, to advocate for this in the break room during the discussions.
I have felt for most of my career that the bedside therapist has got more cred than I do sitting in my office. So that bedside therapist explaining their assessment to the nurse and the doc, not that they just turned the knob on a ventilator, but they did the assessment. So the first, and I think the most important, is for the bedside therapist to have the credibility and respect of other clinicians. Secondly, and I said it twice, so this will be the third time, our medical directors must be educated and engaged. The hierarchy of medicine is the medical director goes to the chief of the division, goes to med exec, and that's where protocols get accepted or rejected. Third, and again, my hierarchy is the administrators. Now, interestingly, increasingly administrators, particularly CEOs, are physicians. So we got kind of a twofer there, Patrick. But if that administrator doesn't know clinical science, What I suggest, and what our committee, more importantly, our committee suggests, we go arm in arm with our medical director and have that discussion with the chief medical officer and the administrator in the room, same time, and lead with, we're here to cut waste. Lead with that, because that's got dollar signs that they're looking at. And paste our value by practicing evidence-based care.
Well, there's no question, as valued members of the healthcare team, respiratory therapists at all levels must assume responsibility to ensure continued access for our patients. And we have to recognize that we're the experts. And so I agree with you. The bedside clinician should have a big say in how that department is going to move forward if they don't have the correct measures for clinical productivity. You have to protect yourself and your patients, and I think that's a very good opportunity for us. Is it not in the best interest of our patients for us to continue to just kind of be apathetic? I mean, that's really doesn't sound like it's going to have much of an impact in a positive manner.
Right. Own it. Own it. And I think, so we want to talk about these resources, of which we've hit the tip of the tip of the tip of the iceberg. Where can they go to find additional information about this resource? The first is, if you're not a member, join the AARC. I cannot imagine having invested time in school and a career not to be a member. So join the AARC. Secondly, join the leadership and management section. In there, particularly with the Connect community, there's a wealth of resources. Hey, quite honestly, it's better than Google some days, Patrick. You see people say, hey, I need a staffing plan for a critical access hospital. 24 hours, you got someone responding to that. The website, in fact, the easiest way to go, I hate 5 clicks to get the information. The easiest way to get to the SESG is the following URL, sesg.aarc.org. You can get through it by going to the AARC website, but why not
Takes a while, sure.
Take the easy button.
So really, there are non-administrative listeners or clinicians who are actually practicing respiratory care at the bedside. They really do have an opportunity now to do a little additional research on their own and then start sharing that with their colleagues as a way to try and get the department to move into a direction that is in the modern era, as opposed to being hung back into the late 80s or 90s, where we just measure, nebulous numbers that don't mean anything in terms of efficiency.
Right. Yeah, treatments done is not a metric that matters anymore. The outcome of care matters. Length of stay, exacerbations, improved breath sounds, readmissions, ED, and urgent care admissions. Those are the metrics that the C-suite look at, not treatments done.
That's right.
Right.
Now, as we conclude this episode, then any final thoughts that you'd like to share with our listeners? I mean, you've actually been a very good wealth of knowledge, and you've approached this from a way that's doable if people really want to take the initiative.
I think, Patrick, just to reinforce, you and I started talking about this 45 minutes ago, but you and I started playing our roles with the AARC decades ago. It needs to start with safety. If it's not safe, don't do it. It needs then to be followed by efficacy. Does it produce? Is it validated? And I think the third leg of the stool is it cost effective? And the way that we address that is by practicing the best available evidence at the time. It may not be a randomized controlled trial. It may be somewhere in the middle of that hierarchy chart, but I may not get this quote exactly, but Maya Angelou said in a presentation actually here in North Carolina, do the best you can until you know better, then do better.
Right.
And I think that's powerful. And the last statement I'll make, which I can't do more than Maya Angelou, rest her soul, is in the beginning, in the end, this system matters because patients matter.
That's right. Well, I really want to thank you, Garry. You've been a great wealth of information, and I think we do probably have several topics where we'll come back and revisit you and have you share more insight. We drill down further on this based upon what feedback we get from our listeners. And let me give that web address a direct link to it. It's the SESG. That stands for the Safe and Effective Staffing Guide. So SESG.AARC.org. It takes you right to the resource department. And I can't tell you what the resources really are like. One of the things that I wanted to just end with is this not just for therapists, but Terry Miller, an educator, is on this resource site saying she's teaching her students about this guide. I mean, that's really thinking outside the box, but why not? Why not get them early on in this? And I think that's really great. Now, you worked with Terry in the past. I think you were a parliamentarian when she was Speaker of the House.
Yeah, we're on several committees together. In fact, workforce development currently. And I go back, I was talking to Dean Hess about this, about protocols. In 1978, you and I were just 6 years old, Patrick, right? But
right.
In 1978, the managers group in central Pennsylvania, which was a charter affiliate of the AARC, got together every month. And we did stuff to help each other out, even though our hospitals competed. And that group put together a program called PORT, Post-Op Respiratory Therapy. Every single department manager that believed in it would practice that. That protocol is in effect today. Mm-hmm. And that was 1978. We know the answer. We know the truth. We need to utilize this resource with our medical director to educate and engage all the others about the science of respiratory care and the science of labor management. They're the same thing.
Right. Well, that brings us to the end of another episode of RT Matters. Thank you again, Garry Kauffman, for your wonderful information. And like I say, we'll probably be having you back later on to talk a little bit more about Safe and Effective Guide. Remember, we always want to hear from you, our listeners, about what you liked about this episode or others, and what we can do better to make RT Matters work for you. And you can also request any additional information from any of our episodes by contacting me at feedback@rtmatters.com. And you'll see that link on the beginning of this podcast if you listen to it. RT Matters is a virtual voice for respiratory therapists everywhere, regardless of your site of practice. So please let your fellow RTs know about this great resource. Now, in the meantime, go out and be the best respiratory therapist you can be, because our patients deserve nothing less. And as a highly skilled, licensed healthcare professional and a member and respected of the healthcare team, we expect nothing less from you. So until next time, be kind to yourself, be kind to others, and remember, RTs do indeed matter. Take care, be safe. When all else fails, choose to be happy.